Okay, great. Welcome everybody to this month's Miami Global Brain Tumor Symposium. Just as reminders, I'm Michael Ivan, one of the neurosurgeons here at the University of Miami and director of this program, and I'm joined by my co-directors, Dr. Komatar, Morkos, and Benjamin, who are all brain tumor and skull-based experts here at UM. Also, can't go on without saying thanks to all of the help that we have each month for these administrators. It's our 49th episode of the Miami Global Brain Tumor Symposium, and we couldn't do it without the help of University of Miami and Sylvester Comprehensive Cancer Center and the Neurosurgical Department. For anybody who's new, please make sure that you could check out all of our old videos. They're all on YouTube. You could easily find them by searching for University of Miami Neurosurgery, and they're all categorized there by either the Global Brain Tumor Symposium or the Cerebrovascular Skull-Based Symposium. It's also Pediatric Symposium and the Resident Symposium, so you could find out whatever you're looking for there. Any other questions about our department, you could obviously follow us on the web or on social media. We want to try to make this as interactive as possible, so please make sure to ask questions. We'll get to all of them at the end of the talk and try to make this as informative as possible for everybody. So this week's panelists, we have a great group here from the University of Miami. Ashish Shah joining us for his first time as officially assistant professor. He's joining us now at our department as director of clinical trials and research. And also he's the PI of his lab, which is focusing on the section of virology and immunotherapy. And we have our three fellows, Dr. Dagabudai, who's joining us from Penn State as our surgical neuro-oncology fellow, Dr. Barry, who's one of our enfolded neurosurgical fellows, and Dr. Morel, who's one of our clinical fellows here as well. Tonight, we have a very special speaker joining us early from the West Coast. I appreciate that. He's a close friend and colleague and mentor of mine. We've known each other now for well over 16, 17 years as residents at UCSF, is Dr. Oren Block. Oren did undergraduate at UPenn, where he double majored in neuroscience and bioengineering, went to UCSF for medical school and residency and also fellowship. And then now he's at UC Davis, where he's the director of neurosurgical oncology, the co-leader of their biomedical technology program, and the PI of their brain tumor immunotherapy lab. His lab has been NIH funded since 2013. He has a tremendous amount of research knowledge on brain tumors, glioblastoma, and immunotherapy, and too many awards and papers to talk about. But really, really grateful and thankful for him to taking out the time today to talk about something that's really interesting, which is LITT and immunotherapy. I think it's a topic that we're all really interested in and has a lot of promise. So Oren, thanks so much.
All right. Thank you very much, Mike, for inviting me. And thank you, everyone, for adjusting a little bit on your schedule to accommodate my schedule and us being out in the West Coast. I certainly have been very interested in the emergence of LITT in the world of neuro-oncology, and I've been following very closely some of my friends and colleagues around the country who have been leaders in the field. And the University of Miami, Mike and Rick, you guys have done some amazing work and published a ton in this space and helped push it forward. I'm a little bit behind you guys clinically, but I hope that some of my immunotherapy background and interest can maybe help guide all of us as we lead forward the approach to using this technology in the world of glioblastoma. And so, I'm going to talk a little bit about LITT in general for the treatment of gliomas, and then combining that with immunotherapy. Sadly, I have no disclosures on this. If the Visualase or Neuroblate people are out there and they want to give me a piece of their company, I'm happy to take it. But right now, I get nothing for any of this work. But it does satisfy me intellectually. I do have some funding from the NIH related in part to the immunotherapy work, which we've then melded with some of the LITT work, although it's not, the funding is not directly applicable to this. This audience is probably very well versed in the treatment of gliomas and glioblastoma, given that this is the, was it 49th or 50th Brain Tumor Symposium? So really amazing. And as you all know, there are a series of modalities that we use for the treatment of this disease, but it really starts with surgery. And the role that surgery has is kind of twofold. I think first and foremost, it's to obtain a tissue diagnosis. because without the tissue diagnosis and without the molecular studies these days, we really can't move forward with any other treatment. But there's also this idea that we're out there to cytoreduce the tumor. And that's been something that I think has been adopted widely in the field due to a number of retrospective studies that have emerged over the past 2 decades. When we are operating on these tumors, we have 2 main goals. A lot of these patients present symptomatic from mass-related lesions, and we want to reduce that mass effect to improve their neurologic function and improve their quality of life. And then secondarily, there's an understanding that cytoreduction leads to an improvement in response to chemo and radiotherapy, and therefore overall survival. And that's been shown in a number of retrospective but good large studies. A real question, though, is what does cytoreduction in that context mean? Does it mean you actually have to remove the tumor, or does it mean that you just have to destroy the tumor? Does ablation without resection accomplish the same thing? And we'll delve into that a little bit. But where it stands right now, maximal safe surgical resection, and I use the word resection loosely because we are talking about LITT, so maximal safe surgical treatment of tumor is really our goal. The idea of the cytoreduction leading to an improvement in survival has been published many times. These are 2 of sort of the seminal papers in the field that kind of set that, the LaCroix study out of MD Anderson back in 2001 and the Sinai and Berger study out of UCSF in 2011. Many studies have followed, but the general gist is that the more tumor you take out, the better patients survive. Some people have looked at these for absolute numbers. It's a different topic than what we're talking about today, but I would argue that it doesn't really come down to a specific number. You don't have to achieve a specific extent of resection or extent of ablation. The take-home message really is that more is better. And those studies were done in the days prior to our current molecular understanding of gliomas. A more recent study published out of UCSF incorporated now knowledge of IDH status and other factors that lead to improved overall survival, both demographic and molecular factors, and showed that in the most receptive groups to treatment, those with the best molecular and clinical characteristics for outcome, they are even more subject to benefit with greater extensive resection. And they've even suggested going after the non-contrast enhancing flare tumor. So a lot of technology has been invested into making extent of resection better. And many of you use these tools. Certainly stereotactic navigation is part of the standard of care almost everywhere. Intraoperative imaging, if you're lucky enough to have an intraoperative MRI, or some of the more affordable tools like ultrasound and intraoperative CT. And then, of course, there's been a huge emergence in fluorescence-guided surgery. Our hosts at Miami, Mike, I know has been a big proponent of this, and we use it quite extensively as well. And I'm not going to talk about it, but we have a whole area of research into both fluorophore and autofluorescent-driven fluorescent-guided surgery. But, we can develop more tools. We can take out that last little bit. We can go from 98 to 99 to 100% extent of resection, super total resection. But what really more can we accomplish? And the reality is that GBM is not going to be cured by more surgery. It's a microinfiltrative disease. It goes beyond the boundaries of what we can see. Even if we could see that microscopic infiltration 1 centimeter, 2, 3 centimeters beyond the margin of the radiographic tumor, we can only go so far without, damaging the patient neurologically. And so in the end, it's going to be some combination of what we do as surgeons with what can be done medically that's going to control this disease. And I would argue that we have today enough tools and enough research devoted on increasing extent of resection where we can do it pretty safely, and we can achieve a near total or gross total resection almost every time if we utilize everything at our disposal. The future is really about changing the way we think about surgery for GBM, so that it's not simply a matter of trying to get the tumor out, but what can we do as surgeons to enhance the efficacy of the medical therapy that follows. And that's where I've become very interested in emerging technologies that not only ablate and cytoreduce the tumor, but have a secondary biologic effect on what's going on the tumor that can be capitalized on with the medical therapies that follow what we do surgically. And so today I really want to focus on the use of laser interstitial thermal therapy for the treatment of gliomas. So many of you are probably very familiar with this. I suppose there are some people on here who may not have firsthand experience with LITT. This technique is basically a stereotactic technique in which we implant a fiber optic catheter into a tumor minimally invasively, and then use thermal ablation to destroy the tumor or induce apoptosis through thermal injury. And the real crux of this, and the reason why this can be safely done in the modern era, even though thermal ablation as a technique has been around for many decades, is that we now have the imaging tools to make this safe. So we utilize a technique called MR thermometry, where we can monitor the ablation in real time under MRI, and we can see the thermal damage that's being done in order to control the areas that we ablate and prevent thermal injury to the areas that we want to protect. There are a couple of systems in use for this, two FDA-approved systems. One is the Monteris NeuroBlate system, which is what we use here at UC Davis. The other is the Medtronic Visualase system, which is used in many centers around the country, I believe at Miami. They both effectively give you the same outcome using slightly different technology and imaging parameters. But basically, what this allows us to do is, through a very, very small burr hole and a cranial bolt, insert this probe into the tumor and, under image guidance, ablate the tumor in a controlled fashion, thereby killing the tumor. And you can think of it as cytoreducing the tumor in terms of live tumor cells, albeit without the actual removal of the dead tumor tissue and tumor mass. And so that's where this technique differs from open resection. The crux of this operation occurs in the MRI scanner, utilizing a laser fiber that is controlled remotely by a workstation that's outside the MRI where the surgeon sits. And in the case of the NeuroBlate system, also using a robotic probe driver that allows us to manipulate the position of the probe as we're doing the ablation. I believe the Visualase system has a manual manipulation to move the probe, but in either case, the probe can be moved into different positions in the tumor, and then ablation happens under image guidance. And this is what we see as we're ablating. And effectively, what we're doing is we're treating to certain biological thresholds of heating. So as we ablate, the software calculates thermal damage threshold lines. Here you can see the yellow line that's developing over time. This is sort of a sped up version of what we're seeing on the workstation. We monitor 3 thermal damage thresholds, a yellow, blue, and white threshold, which correspond to heating of the tissue up to a certain temperature and the biologic equivalent of maintaining it at that temperature for a certain period of time. But effectively, the highest thermal damage threshold, the white line on the Monteris system, is the equivalent of coagulative necrosis occurring from very high heat. The intermediate line, the blue line in this case, is the equivalent of thermal damage that will lead to total necrosis and apoptosis of the tissue over a delayed period of time. And the yellow line is a reversible heat injury line where some tissue will undergo ultimate apoptotic cell death, but some of the damage will be reversible and recover, the so-called sort of penumbra of the thermal injury. Depending on what kind of tissue you're ablating, you may want to take the margin of the lesion out to a different level. So when we're treating radiation necrosis, we're not as concerned about complete ablation. So we usually take it to the lowest threshold margin, and that does a nice job of controlling radionecrosis associated edema. But if we're treating a tumor, what we want to do is take it, to the full thermal injury. So usually the blue line out to the margin of the tumor where we get, full ablation and necrosis of the tumor cells. This is truly a minimally invasive procedure. I know a lot of people say that they do MIS surgery through eyebrow approaches with, endoscopic assisted surgery. And I do all of that and I love it. And it's definitely better than a big open bicoronal incision. But this is MIS surgery in the brain, right? It is a small stab incision, a tiny burr hole, basically the size to allow you to place a cranial bolt, and then a minimal procedure done actually in an MRI scanner, mostly outside of the OR. And at the end, what you have is a minimal wound that closes with a single stitch and leads to really minimal pain, very rapid healing. And beyond the fact that it is minimally painful, certainly in comparison to any size craniotomy, and is associated with a minimal length of stay. So our average patient stays less than 24 hours after completion of the procedure. And I don't send any of them to the ICU unless there's a complication, but knock on wood, we have yet to have a complication related to this procedure that requires an ICU stay. So really, these patients are in and out, and I could conceivably see in the future even sending them home immediately after a quick PACU stay. Although at this point, we're still, for safety reasons, watching them just overnight. But even beyond that, the degree of tissue injury and the need for wound healing is so small that I don't stop patients' chemotherapy or other systemic therapy when we're treating patients with recurrent disease or, say, metastases who are undergoing systemic therapy for their primary disease. And I'll even treat patients on Avastin without delaying or holding Avastin doses. I have yet to see a wound complication from this small incision. And so that's really powerful. And for reasons that we'll talk about here in a minute, immediate chemotherapy after LITT may have some true biologic benefits. And it's something that you would only consider doing in this type of minimally invasive approach. So is it safe? That's a question that's been asked and I think well answered in the literature. The users of the NeuroBlade system around the country have contributed cases to a central registry called the Lantern database, which has published their results over time in terms of pooled data. This is, of course, all retrospective data from multiple centers. But a couple of years ago, they published the latest outcomes of treatment of primary and metastatic tumors, over 200 tumors in total treated. And really, I want to focus on the complication data, where total complications in this retrospective cohort were under 2%. And for primary tumors, so gliomas, both high and low grade, as well as meningiomas and a few others, were even lower than that, along with a very short length of stay and a very high percentage of patients discharged home, not requiring rehab or skilled nursing facility admission. The Miami group also published their experience with Visualase and also demonstrated an exceedingly low complication rate for a variety of tumors treated. And these numbers are well below that of open craniotomy for certainly gliomas and probably even for metastases, which have a slightly lower complication rate. So I definitely think we can say that this approach is safe. But now the real million-dollar question, is it effective? And that is something where the data is still emerging, just because this is a new technique. But there is a paper that very recently came out in Neuro-Oncology Advances, again, out of the Lantern group, looking at the efficacy of LITT treatment for newly diagnosed and recurrent IDH wild-type glioblastoma. This, again, is a retrospective analysis of registry data. So this was not a prospective study and was not controlled in any way. And the most important thing to remember is that this is subject to the selection bias of who was chosen to be treated with LITT versus the standard open craniotomy, which is far more used and the standard of care for newly diagnosed and recurrent GBM. But there's still some lessons to be gained out of this. So if we look in particular at the newly diagnosed data, because I think that's a little bit cleaner than recurrent patients who've been treated with a variety of modalities, we see that overall the survival data is not particularly impressive. So the post-treatment survival on newly diagnosed patients here was under 9 months, which is way below what we would expect for surgical treatment of newly diagnosed GBM. But we have to remember that these were a heavily selected population of patients, most of whom were treated with this technique because they were poor candidates for open surgical resection. They either had tumors in deep, eloquent regions that were already highly symptomatic, they were very sick and not really great candidates to undergo a multi-hour craniotomy under general anesthesia. And it's reflected in the fact that a large proportion of them didn't even go on to complete standard chemo and radiotherapy. So if you look in the subdivision of the newly diagnosed patients, you see those who actually completed standard Stoop protocol chemo and radiotherapy and those that didn't. For those that did complete the Stoop protocol, they had an average survival from treatment and progression-free survival that mirrors what we expect with the standard of care. So about 15 to 16 month overall survival from diagnosis with a 12-month progression-free survival. That is matching what we see in all of the large phase 3 studies for a variety of treatments in newly diagnosed GBM. It doesn't exceed it, so it's certainly, they're not doing any better than the standard of care, but it doesn't seem that they're doing any worse. The overall average, this less than 9 months, was really dragged down by the patients who didn't complete therapy, who had a very poor overall survival, but probably were kind of doomed to that at the start, which is why they were chosen to be treated with LITT rather than an open resection. So is it effective? It's probably similar in efficacy to open surgery. I think that real head-to-head prospective trials are still very much needed, but this data suggests that it certainly could be. But there's also safety data that came out of this. And if we look at the adverse events data, here it's a little bit higher than what we've seen in some of the previous publications, but still on the order of what I would call very safe. So total complication rate, about 13.5%, but neurologic deficit following treatment on the order of 5 to 6%, which is similar to, if not better than, open craniotomy, and a total complication rate, which includes all those other medical complications, DVT, cerebral edema from treatment, postoperative seizure, is what brings it to that, again, on par with open surgical resection. So far, what I would say is that this technique is certainly very safe, perhaps even safer from a neurologic perspective than open craniotomy. And its efficacy seems to be on par with open craniotomy, not better as a standalone treatment, but certainly an alternative, right? And because of the other benefits, the patient comfort, the limited length of stay, the lack of need for ICU, you might say, well, just the fact that it's minimally invasive, easy to tolerate, and in studies where they've looked at patient satisfaction and overall function, quality of life seems to be very good after this treatment. Why would we not move to this for everything? The same way, a lot of open vascular has moved in the endovascular direction, and a lot of spine has moved to the MIS direction for equivalent outcomes with less pain and suffering. Well, one issue, of course, is that, as we talked about at the beginning, one of the major reasons that we even operate on at least newly diagnosed GBM patients is to treat mass-related symptoms. And this technique, while ablative, doesn't really get rid of the mass effect. If anything, it might make it worse. So those of you who do LITT know that when you ablate a tumor, as has been shown many times, the initial response over the first few days to weeks to even 3 months is actually that the dead ablated cavity tends to swell up. Sometimes there's an increase in surrounding vasogenic edema. There's definitely an increase in the size of the primary mass itself, and it can take months, sometimes up to 6 or 12 months, to then see that involute and see the regression of the primary lesion. And that's fine for a small MET or a small recurrent GBM, but if you've got a 6-centimeter primary tumor, even though that's hard to ablate the whole thing anyway, it's going to take multiple trajectories and so forth, you can do it, but you're going to see probably a 20 to 30% increase in the total volume of that lesion in the early stages, and there's no way the patient's going to be able to tolerate that increase in mass effect. But there is a solution to that. So Andy Sloan actually published this idea back in 2016, which was treating patients with large and difficult to access brain tumors with LITT, and then following that with a minimally invasive tubular resection of the tumor to relieve the mass associated with the lesion. And I know that this has been being done kind of as a routine at a number of centers around the country, MD Anderson, WashU, and it's really something that we've taken to heart. And so we've started treating, quite a number of newly diagnosed GBM patients, usually with tumors in areas that are not great for open resection, but also in kind of older patients. So here's a patient in his 80s with not a particularly large tumor that could be resected with open surgery, but he was already a little bit symptomatic. He was not in the greatest health. And so rather than doing this as an open craniotomy, we opted to treat this with LITT. So here you can see the intraprocedural ablation of that lesion. You can see the typical response. So this is still in the scanner with the fiber probe in place. We see what used to be a very avidly contrast enhancing tumor with some central necrosis, now having just a thin rim of enhancement with a large area of central hypodensity and necrosis and a little bit of internal hemorrhage. And this was, when you look at the TDT lines, completely ablated to the blue line over the entire volume of the tumor. But if you actually measure this out, and we did do volumetrics on it, I haven't shown it here, there's already at the very end of the procedure compared to the pre-procedure scan, a 15% total volumetric increase in the size of this lesion. And if you wait another week or two, it's probably going to get to 20 to 25%. And this is already putting a little bit of pressure, on the peduncle, on the hippocampus. He's having some memory issues, a little bit of mild hemiparesis. And so we'd like to get this mass effect off. And we did our standard approach, which is to wait 24 to 48 hours for this ablated tumor to centrally necrose and liquefy. And then we went in and made a small incision and placed a Vicor tube through a small transsulcal approach and just sucked out the dead tissue. The goal here is not a gross total radiographic resection because you've already gross totally ablated the lesion. Our goal here is simply to get the mass effect off. And so we just suck out anything that's liquid and the end result is pretty good. So most of the tissue comes out because it's just dead and easily suckable. You can see that there's still a little rim of enhancement around here, but this is post-ablation enhancement, not live tumor. And we've done this for a number of patients with really nice results and the same rapid healing and next day discharge with great outcomes. So, why do this, right? Well, I could have just put a tube retractor down and probably resected this thing without the ablation ahead of time. A lot of you are probably thinking that, and I completely agree. This could have been done minimally invasively without the extra LITT step. But there are some added biologic benefits to having done LITT prior to the resection. First and foremost is the permeabilization of the blood-brain barrier. So the WashU group has really been the leaders in talking and publishing this. Eric Luthart published a paper a number of years ago looking at delayed contrast MRI post-LITT and showing that there was an increase in permeabilization and gadolinium distribution following LITT that lasted for about 4 weeks after the ablation, and then the blood-brain barrier closed up. And this is kind of an ideal window for trying to get drugs that are not particularly permeable to the blood-brain barrier in during kind of a therapeutic window. This led to an animal study by Albert Kim, where he treated mice with implanted tumors with LITT and then gave them systemic doxorubicin, which does not cross the blood-brain barrier in humans or mice. Now, if you look at the survival curves, the mice treated with doxorubicin alone didn't really have any better survival than control. Mice treated with LITT alone did show an increase in survival, but mice treated with LITT and doxorubicin had an additive improvement in survival, really because the LITT permeabilized the blood-brain barrier and allowed the doxorubicin to get in there. That has led to a number of human clinical studies, one which was recently published by the WashU group, where they actually treated human patients with recurrent glioblastoma with LITT and doxorubicin. We could spend a while diving into the details here. This study is actually kind of interesting because they treated patients both in an immediate and a delayed fashion We would have expected, based on their old timeline, that the early treated patients would have the better survival, but it actually turns out that the patients treated with doxorubicin in a slightly delayed fashion demonstrated the greatest survival compared to patients treated with bevacizumab or laser ablation alone as historical controls. There may be a number of reasons for this. I think this data needs to be examined a little bit more closely, but that's not really the goal today. Simply to say that a drug that really shouldn't have any effect in recurrent GBM is having an effect after LITT treatment. And this has led to a number of other clinical trials. So there are a few clinical trials right now open and enrolling for immediate postoperative CCNU treatment following LITT for recurrent GBM, with a plan to start the treatment within a week or two of the laser ablation. Again, this is only possible because of the minimally invasive nature of LITT. LITT allows us to make a minimal incision. We don't have to worry about wound healing, so we can start cytotoxic chemotherapy immediately after the treatment without the concern about the wound opening up. So that's a basic biologic advantage that applies to any kind of post-LITT therapy. But what about specifically the impact of immunotherapy in combination with LITT? So a lot of people have postulated about this, and Pete Fecci published a really nice kind of theoretical review article recently looking at the reasons why LITT may be an immune stimulant. So as I mentioned, there are three kind of zones that we look at that have different physiologic activity. We look at them as different thermal damage threshold lines, but really what you have is a central core of necrosis, sublethal cell damage, and then hyperthermia with reversible cell injury. And each one of those activates the cells that are within it in a different way, causing cell death, necrosis, release of cytotoxic chemokines, and that then activate secondary immune infiltration, theoretically, activation of heat shock proteins, which have a number of different antigen presentation and chemotactic activity. And this theoretically leads to an infiltration of antigen presenting cells that will scavenge the dying cells that are ablated, pick up the neoantigens from the tumor and deliver those to the nearest cervical lymph node, where they can be used to stimulate a T cell response. And then that T cell response is drawn into the tumor by the cytotoxic factors and the chemokines that are released during the cell death. Again, this is very theoretical. It has not actually been proven in studies, either animal or, more importantly, out of human tissue, that this is truly occurring. But we are kind of extrapolating from the kind of injuries that we know and responses that we know happen with other kinds of treatments, such as stereotactic radiosurgery or even fractionated radiotherapy, that seems to activate some of the same pathways. And it has been proven that these activities do occur with those types of treatments. So on the basis of this theory, a number of clinical trials have already launched. And there are 3 trials that are open and enrolling right now, looking at the use of LITT plus an anti-PD-1 immune checkpoint inhibitor for the treatment of recurrent GBM. These are all early phase 1-2 trials at single centers with accrual of anywhere from 30 to 50 patients planned. And they're all currently open and enrolling, or may have even finished their accrual, but haven't reported any results yet. So we certainly look forward to these, to the outcome of these studies, but jumping right into them may have been a little bit putting the cart before the horse, because we still don't really know biologically what is happening inside the tumor. And we have to remember that this comes on the heels of some less than impressive data on the use of immune checkpoint inhibition, particularly anti-PD-1 therapy in GBM in general. So those of you who follow this know that there were a couple of studies by Bristol Myers Squibb, the Checkmate 143 and Checkmate 498 studies, that looked at the use of anti-PD-1 therapy for the treatment of both recurrent and newly diagnosed GBM. And there is currently an ongoing study, the NRG BN007, that's looking at the same factors, anti-CTLA4 and PD-1 therapy for methylated newly diagnosed GBM. But basically, the ones that have been published already or have reported results demonstrated no true efficacy. So in the recurrent GBM study, where it was compared against bevacizumab, there was no benefit to nivolumab against bevacizumab. The Checkmate 498 study actually closed early because it was not going to reach its primary endpoint for success. And so clearly, checkpoint inhibition by itself, and in the case of the Checkmate 498 study, that was in combination with radiation therapy at new diagnosis, didn't really have efficacy. So why not? Why did these studies fail? There's a lot of different reasons, and there have been numerous papers written on all the different immunosuppressive factors in GBM. But I just want to point out that these drugs come from a different world where they are highly successful. The world of certain immunotherapy responsive cancers like melanoma, certain types of lung cancer. But there is a big difference between those tumors and GBM. Those tumors metastasize hematogenously and through lymph nodes. They have a lot of innate autoimmunization, and they exist in tissues that are rich with macrophages and dendritic cells that assist with that autoimmunization and drainage to local lymph nodes. They have high somatic mutation burdens, which means a lot of neoantigens for autoimmunization, and they are relatively homogeneous tumors. Compare that to glioblastoma, where there is no extracranial metastasis. There's relatively limited lymph node drainage, and what lymph node drainage there is probably passes through CSF first. So it's bulk drainage through CSF into the sinuses and then into perisinus lymphatics, where there's a lot of dilution. So the amount of antigen that really makes it to the lymph node is much less. There's alternative antigen presentation. So a lot of antigen doesn't even go to dendritic cells that can leave the CNS. It's presented by microglia and astrocytes. There are lower somatic mutation burdens and very high tumor heterogeneity. And all that ultimately leads to a relatively cold tumor compared to the tumors that respond to immunotherapy. And so what we get when we look histologically in GBM are tumors that look like this. At baseline, almost no T cell infiltration within the tumors, but very high myeloid cell infiltration, both activated microglia and infiltrating macrophages. And many studies have been done, including by my lab, at the nature of this myeloid cell infiltrate. And it is almost exclusively immunosuppressive myeloid cells. So M2 macrophages, classic MDSCs, non-classical but suppressive microglia. These myeloid cells that are both coming in from the periphery and stimulated innately within the tumor are really shutting down the possibility of any immune response. And they are probably a large part of why immune checkpoint inhibition by itself fails for the treatment of GBM as a whole. So not much is known about what these cells are doing following LITT. And I think that that's an area that really requires some investigation. And it's something that we've been very interested in and actually doing. So when we treat LITT patients, we always do a biopsy to confirm the histology. And it gives us the opportunity not only to biopsy the tumor itself, but to take multiple biopsies along the LITT track. So here we are taking that biopsy before the laser fiber implantation in a patient. And we're taking biopsies in the peritumoral normal tissue, at the tumor edge, where there's contrast enhancing tumor meeting normal tissue, and then in the necrotic center of the tumor as well. And we annotate these biopsies on the navigation because in a lot of these cases, we're going to take these patients back and then resect the ablated tumor for mass-related symptoms afterwards. And when we do that, we can fuse the MRI from the initial biopsy and LITT to the post-LITT MRI and navigate ourselves back to those exact locations and re-biopsy the same exact site that we took prior to LITT at 24 or 48 hours after LITT, and do comparative histology. And so we've been doing that. Here's an example of a patient tumor where we took 3 biopsies. I want to focus in particularly on the marginal biopsy right here at the edge of the tumor. So this is what it looks like pre-LITT under H&E and immunostains for basic immune infiltrates. CD3, which is a T cell marker, CD68, which is a pan-myeloid cell marker, so it will highlight microglia and infiltrating macrophages, and CD163, which is a suppressive myeloid cell marker. So it's really looking at that M2 like phenotype. And we see what we typically see in GBM, which is basically no T cells and a relatively high number of myeloid cells with suppressive phenotype. If we look at 24, or in this case, I think it was 48 hours post-LIT from that exact same site, this is what we see. So we see a lot of internal necrosis and cellular damage from the ablation, which makes sense. That's what we want to see. We see some background staining, but not really any real CD3 infiltration here. You're seeing a little bit of brown, but that's mostly background. But when you look at the macrophage infiltration, it's massive, right? And it totally makes sense because what you have is necrotic dying tissue. And what does that recruit? It recruits macrophages to scavenge and clean up all the dead tissue, right? We see the same thing in stroked out brain. We see the same thing in post-trauma brain. You know, you have injured tissue and there's a macrophage response. But when we look at the CD163, a lot of it is a suppressive myeloid cell response. And so this is taking what normally occurs in GBM and actually activating it to a very, very high degree. And so I would call this environment that we're seeing hyper suppressed. And so it raises the question, is immunotherapy really going to be effective? Well, to study this even better, we took it into an animal model, right? Because there's only so much you can do in humans, but you can do a lot in mice. And so in mice, we've been implanting mice with GL261 tumors in immunocompetent C57 black mice, and simultaneously implanting a laser cannula that we can then use to ablate the tumor 7 days post-tumor implantation when the tumor has actually developed into a measurable mass, and then follow this with serial blood and tissue studies and serial imaging to see what happens to these mice. So here's an example. This is what the laser cannula looks like. We've actually co-opted optogenetics cannulas that are implanted and have a connection cannula so that we can free the mice to run around. And then when it's time to ablate them, we use a connector to ablate them to a laser fiber source. We use a solid state neodymium YAG laser, which is similar to what's used in clinical LIT. And you can see here that, you know, here is pre-ablation, a nice implanted tumor with the laser fiber right at the edge of it. We worked a lot with the parameters so that we are ablating every tumor exactly the same with the same laser intensity and for the same amount of time, with the goal to achieve subtotal ablation. We want to injure the tumor and get an inflammatory response, but not actually completely ablate the tumor and cure it. We want the tumor to go on and continue to grow. And so we can see histologically before the ablation, we have a typical tumor, you know, GL261 tumor here. Post-ablation, there is a massive inflammatory response, right? So these are T2 MRs. We're seeing a lot of inflammation. And then 7 days post, that inflammation has died down. There's still a tumor there. There's a lot of necrosis. But if you continue to follow this out, the tumor does begin to grow again. And ultimately, the mice do die from this. If we look at what happens here, we see that we are getting, you know, pre and post LIT over a 7-day period in most subjects, a relative restriction in tumor growth, although it does still grow a little bit in some mice, more than a little bit. And if you look at survival, the LIT treated mice, this is with LIT alone, do survive significantly longer than just sham control mice that have an implanted catheter but don't get ablated. But all mice do eventually die. The tumors do continue to progress. If we look histologically, what we see is very similar to the human condition. So that in sham-treated and tumor-only mice, we see a little bit of a myeloid cell infiltration, but post-LIT, a significant increase in myeloid cell infiltration within the tumor. And if we look peripherally in the peripheral blood of these animals, we actually see an immunosuppressive environment with an increase in circulating regulatory T cells and a decrease in circulating CD8 cells, along with an increase, I'm not showing it here, but of PD-1 expression on those circulating T cells. And we were also interested in knowing what happens to circulating interleukin-6 levels. And it turns out that they rise substantially. So why interleukin-6? What's my interest in that? You know, my lab has shown over time that myeloid cell biology in GBM patients, both in the tumor and in circulation, shows a dramatic increase in suppressive myeloid cells peripherally and intratumorally, and that is driven in large part by IL-6 derived from the tumor and peritumoral vasculature. And we published a study in Clinical Cancer Research back in 2019 showing that when you treat these tumors with anti-IL-6 antibodies, what you see is a substantial decrease in intratumoral myeloid cell activity and a substantial increase in intratumoral T cell activity, which also corresponds with a decrease in tumor size and growth and an increase in animal survival. And when you combine anti-IL-6 therapy with anti-PD-1 therapy, you get a synergistic response with more than 50% of subjects having long-term survival. And so we believe that IL-6 derived from the tumor is an important factor in driving the anti-tumoral, immunosuppressive tumor myeloid cell response. So what happens to IL-6 when you thermally ablate? Well, any kind of damage, radiation, or thermal injury is known to activate the JAK-STAT pathway, which is what regulates IL-6 expression. And there's a lot of data on this from hepatocellular carcinoma because thermal ablation in HCC and for tumors in the liver has been used for a long time. So if you look at either radiofrequency ablated or laser thermally ablated tumors in the liver, and you look at both intrahepatic IL-6 levels and serum IL-6 levels, you see that they rise significantly from baseline after treatment. And when we look in our human tumors pre and post LITT from the patients we've treated, if you look at IL-6 expression within the tumor, this is about normal and expected pre-ablation. It is massively upregulated within the tumor, which explains why we're also seeing that massive increase in myeloid cell activity. And so the conclusion that leads us to, at least at this point in time, is that LITT is safe and effective as an alternative for the treatment of GBM. I think it's an alternative to cytoreduction. It's minimally invasive, reduces pain, reduces length of stay, and is associated with what is probably an equivalent survival and a maybe slightly improved complication profile. But for patients with large symptomatic tumors, it's got to be combined with some kind of resection to address mass effect. LITT has potentially the ability to stimulate an immune response, but we have to address this issue of IL-6 production and maybe a number of other pro-myeloid chemotactic factors that are produced by the ablation and the effect of that myeloid cell infiltration into the tumor. And so I suspect that the studies of LITT plus anti-PD-1 therapy alone are going to be marginally successful, if at all, similar to anti-PD-1 therapy for GBM as a whole. But perhaps by using a myeloid-directed therapy like IL-6 blockade plus immune checkpoint therapy, we might get a synergistic response. And that's what we're working on investigating in animal tumors right now. So I just want to highlight a few people who have been sort of critical to doing these studies, former and current lab members of mine. And I want to thank you all for your time, and I'm happy to take any questions that people have.
Thanks so much, Oren. That was awesome. That was a great talk. I wanted to open it up to the panelists first to see if they had any questions, and then I have a couple. Ashish?
Yeah, thank you so much. That was a really fantastic talk. We've been really interested in LITT for newly diagnosed gliomas for a while now, and studying the immune response has been something we've been interested in. A few thoughts. I think, I guess my question is, I think you guys are standing for CD68, post LITT, like I guess 24 hours afterwards. Do you guys find a change in the immune profile of these patients, weeks after LITT, like 6 weeks to 8 weeks after LITT, if you were able to, biopsy these patients afterwards? Because I imagine that immune landscape changes over time. So that's my first question. And then I had some patients I wanted to get your opinion on to see what you thought as well.
Sure. I don't know the answer to what happens in a more delayed fashion because, of course, we've never biopsied them because we don't really have a indication to. And that is the struggle with human studies, where that data is clearly the most important to what we do, but ethically we can only do so much. And so recurrent biopsies without real clinical benefit to the patient are kind of hard to do. I suppose there are some early recurrence patients who might be good candidates for that. And if we ever get one, we will definitely save tissue. But so far, none of the patients we've treated in this way have needed any kind of early re-resection or intervention. We do see it in the in the animals. So that's the benefit of the mouse model, is it allows us to look at a variety of different time points. We have not seen much of a change in the infiltrate over time. So if you look very early at 1 week post-ablation, it's mostly myeloid, very limited lymphoid infiltration. Even if you look several weeks out after that, maybe there's a little bit more lymphoid than what you see in the sham controls, but it's not an overwhelming switch in the response. We are not in just the LITT treated mice without any other systemic therapy seeing any kind of dramatic delayed lymphoid immune response. And so I think that should be concerning for the clinical trials that are looking at this right now. And it's clear that something in addition to LITT has to be done to stimulate that response.
I see. Yeah, we've had some interesting kind of results. I kind of just want to show you quickly just a few patients that we've kind of treated.
Yeah, absolutely.
On time. This is a young female, about 45 or 46, who presented with seizures. I think to Rick, and presented with this lesion. Given the location, we thought it would be a good candidate for basically LITT alone. We actually tend to favor just doing biopsy and laser thermal therapy alone, and then kind of getting them on this 2 protocol as soon as possible within the week. So a little bit different from the biopsy and resect kind of protocol. And this patient, this is in the fiber catheter. He got about some 90% ablation. Not clearly didn't ablate the entire tumor given the size. But you can see, this is the post-ablation images. So I'll just skip to the points. This is pre-op. 3 months afterwards, you can see there's some small shrinkage of the tumor. 7 months afterwards, now on STU protocol, some improvement in the size of the lesion. 24 months, this is IDH wild type, MGMT unmethylated, GBM. 24 months now, you can see barely any tumor. 48 months, again, barely any tumor. And then after only 50 months, she had a small recurrence anterior to the area where we did our LITT. So, something about some patients, tend to respond to LITT much better than other patients. And, given her molecular classification, I don't know why this patient, had a more favorable response than other patients, but, I think something in the genetics maybe something worth looking into on why certain patients respond well. So I want to kind of get your opinion if you've thought that maybe certain patients have a phenotype that's more susceptible.
Yeah. I'm curious, did you sequence this patient's tumor by any chance? You probably didn't have enough tissue from just a biopsy, right?
Well, we have enough. I mean, I can look back to see if they did next gen sequencing. Unfortunately, like 5-6 years ago, our pathology was, developing. It's like so now we've kind of progressed now to the more next gen sequencing. So I'm not sure if it was sequenced, but I can check to see if there's any archival tissue we can check.
So one potential explanation, I mean, again, there are long-term survivors and we just don't know who, we're not good at predicting those people regardless of the treatment. But I do think that, just anecdotally in a number of patients that I've seen who were treated with a variety of, modalities that you would expect to be immune stimulating, including the ever so popular unintended cranial wound infection. The really long-term survivors I've seen, the few that we have sequenced their tumors, turn out to be high tumor mutational burden at baseline, right? So if this patient did have a particularly high TMB and a very hypermutated tumor to begin with, and LITT stimulated even some autoimmunization, it's possible that this patient had better autoimmunization than average and therefore got a nice immune response from that. It's also possible that your LITT really did, because we don't even truly know biologically what's happening at each thermal damage threshold, right? There's sort of this teaching that's been pushed along about what each thermal line means and whether there's reversible or irreversible injury there. But different tumors are going to respond in different ways. And perhaps, you really did get a, total to super total treatment of this tumor, even though you didn't get your highest, TDT or second highest TDT out to the tumor margin. You might have still had some kind of thermal, injury that, coupled with rapid Stoop protocol, led to cell death all around. And you got enough suppression of the, of the microscopic margin and cancer stem cells to really get a very nice, long, durable response. I mean, it's all conjecture,
Right.
but I think the strong argument there, is that there is a biologic response beyond simply the cytoreduction, and it could have just been the permeabilization of the blood-brain barrier, and then the rapid, temozolomide after that. The one thing I will say, if you go back to that, is, you guys, it looks very nice here. In some sense, got lucky that there, and maybe we're just not seeing the imaging, that there wasn't a massive inflammatory response to the radiation afterwards.
I'm going to show you that.
The reason we tend to go in and resect is because, if you just biopsy any tumor, I mean, forget LITT, if you just do a biopsy, don't resect the tumor, and then you give a whopping dose of radiation, it always looks worse on the next scan. And then it raises all these questions about, is this true progression, pseudo progression? Do we need to go back in and biopsy? Patients a little clinically worse? Do we give steroids? Do we give Avastin? It just raises all these things. I find that the cytoreduction after the LITT, or I mean, the resection of the dead tissue after the LITT, takes all that kind of stuff off the table. And then we usually don't have to deal with the visual changes that might be good and they might be bad, and we just don't know what to make of them. So that's mainly the reason why I like sucking out the dead tumor after the fact.
Yeah, it completely makes sense. I mean, I think I think we've had a few patients who have had a lot of swelling afterwards, and this kind of raised some concerns with the radiation oncologist, but we kind of calmed them down. But this is a good example of that. This is a patient, this is early on. This is like, I want to say about 8-9 years ago, where when LITT was first being introduced. So this is a patient who had this kind of frontal lesion. It was kind of unclear what it was, underwent biopsy and laser thermal therapy. Here you can see we kind of did a super maximal ablation of this lesion. Here's the thermal dose lines, then started on Stoop protocol, IDH wild type again. And, this is, after Stoop protocol, chemo, radiation in the middle, you can see this kind of mass effect, patient becoming a little more confused. And so we, went back and did kind of a frontal lobectomy on this lesion. And interestingly, when you look at this lesion under the microscope, you can see, lymphocyte infiltration, within the lesion. And, a lot of macrophages, but definitely some CD8, CD4 lymphocytes in here. So this was like, 6 to 8 weeks, during chemoradiation. So I'm just, I'm a little, that's why I asked you about the time course, because this is kind of an interesting patient. Again, this patient after the frontal lobectomy, long-term out, 5-year, 6-year survival now after this. So that was quite impressive. And, I'm obviously showing you a select group of patients, but certainly interesting from that perspective.
Yeah, I mean, this one clearly, this is pseudo progression, whatever pseudo progression is. Right. It's not really radiation necrosis. It's some sort of inflammatory response to all the cytotoxic therapy, LITT, radiation, chemotherapy, leading to massive inflammation. And so we do expect, immune infiltration. It should be dominated by macrophages, but I think it's reasonable to see a lymphoid response. I think what's interesting, and that's where prospective studies and figuring out some way to get delayed tissue is, you might expect to see that here because you're seeing clinically and radiographically such an immense inflammatory response. What's going on in the patient where you do LITT and it looks, it doesn't change at all, right? Yeah. You get serial scans, it's not growing, it's not shrinking, it just looks like whatever it looks like. Are they getting any kind of immune response? And if they're not, what's different about this patient than those patients?
Absolutely. Thank you. I probably overtook my time. Sorry, Mike. But thank you again for your input. Really appreciate it.
Cases. Alexis?
Very interesting. So very, very interesting. I did have a question. Do you think supramaximal ablation volumes, including more than in the enhancing part of the tumor, can be beneficial in patients with gliomas, especially in the context of unavailable postoperative adjuvant treatment?
Yeah, so I'm definitely a believer in supramaximal treatment when possible. And so whether that's, supramaximal resection, if you're doing it open, or supramaximal ablation if you're doing it by LITT. I think the challenge, of course, is that the number one predictor of outcome, a little bit because it's a self-fulfilling prophecy, is functional outcome, right? If a patient is neurologically injured and debilitated and has poor quality of life, that always leads to worse survival because they have more medical comorbidities. They're less likely to then seek secondary and tertiary therapies when their tumors recur. And so anything you do has to be, safety first, preservation of quality of life first. I would say it's more the minority than the majority of cases where supramaximal ablation or resection is possible, just because oftentimes, at least in my patient population, patients present because of symptoms. There are not a lot of incidentally found high-grade gliomas in my population. They're usually symptomatic. And so by the time they're symptomatic, it's a big tumor and it's a budding something eloquent that caused those symptoms. And so there's only so far that you can go. We certainly overtreat in all the directions that we can. So if it's a budding on its posterior end corticospinal tract, I'll overtreat anteriorly, but there's a limit to where you're going to go as you approach the functional tissue. And I think definitely, being conservative for preservation of function has to trump any kind of attempt at being super maximal with your resection.
Perfect, thank you.
Okay, Leifer?
Yeah, thank you so much. This was a great talk. And I think, as you said, a very interesting technology going forward. I was interested by the study you had shown about the doxorubicin and the result after laser interstitial therapy. How long have you found, or do you think that after laser interstitial therapy that the blood-brain barrier will be permeable? And do you think there's any role in recurrent cases to either early start chemotherapy or other treatment modalities after laser interstitial therapy, trying to utilize that kind of open blood-brain barrier and maximal treatment?
Yeah, I mean, I'm going off of other people's data. We haven't done any of these studies ourselves, but Eric Luthard and Albert Kim have published and given talks on this extensively. Their data seems to suggest a window of about 4 weeks of really maximal BBB permeability after treatment. But I definitely, looking at their data, I'm a big believer in it, and I try to utilize that to our advantage. So when I treat recurrent GBM or any recurrent glioma with LITT, I make sure actually that we have decided on our next round chemotherapy and that it's prescribed and ready to go. So often it's CCNU or something like that. And I will have our neuro-oncologist prescribe it, and the patient has the pill in hand, and I tell them to take their first pill as soon as they get home from their procedure. So I try to get as much chemotherapy into them as early and as fast following LITT to capitalize on that blood-brain barrier permeability. The doxorubicin study is interesting because it seems to suggest that that's happening, although it's a little hard to interpret why. So their early and late cohorts were within 6 weeks and after 6 weeks of LITT treatment. And interestingly, they had better survival and a statistical improvement compared to their control cohort in the late group, but not in the early group. And so I don't really know what that's about, to be honest. And there were some suggestion that maybe the late group also got more rounds of treatment at a further period. I mean, they tried to correlate it with the length of treatment rather than with the timing. But the reality is it's not an intuitive result, but nonetheless interesting. And I think it's something that needs to be studied. And there are a couple more studies of lomustine following LITT for recurrent GBM that are running right now. So I look forward to their data.
No, I think, as you said, that early chemotherapy, especially the recurrence, is super helpful in terms of maximizing the treatment and utilizing the blood-brain barrier opening. That's really cool.
Okay, great. I have one more case for you, Oren. Let's see. So this is a patient of mine here that he's a lawyer, presented with this with a little bit of weakness on the left side. I mean, on the right side. When you look at this scan on T2, a lot of this stuff that's kind of center in the ventricles was CSF filled, which is kind of this fine line of enhancement,
Mhm.
and most of the solid stuff was here in the thalamus. You know, very challenging to treat regardless. But you know, how would you kind of go about this? What options would you think?
Yeah, so this is interesting. I was just talking to our residents about butterfly gliomas earlier today, and should you touch them or leave them alone? I'm on the very aggressive side of things always. So I think everyone deserves a shot at treatment, and I think that he's certainly going to benefit from some degree of treatment here to enhance the efficacy of radiation and chemo. I think this is kind of a perfect LITT candidate. What I've done in the more anterior and posterior, this is a really tough location, right? So in the callosal or midline butterfly gliomas that are either far anterior or far posterior in the splenium, what I usually do is an open resection of the safer side or larger side, and then come in and LITT the other side so that I don't kind of do a bilateral cranie or try to chase it too far across, but ablate everything. In this case, there's really I don't think there's a terribly safe approach. I mean, you wouldn't really want to tackle that left side open regardless. So I think this is a perfect case for LITT, but it is a lot of mass effect, right? And I think that if that gets worse and then him needing radiation, he's going to have a tough time tolerating that. So this would still be one where I would probably try to LITT the whole thing first and then come in with some minimally invasive approach and try to suck out as much as I could. In this case, I might do it mini open and do sort of an interhemispheric approach, get into that corpus callosum and hope that the left side that was ablated is so liquefied that it just kind of collapses into the suction.
Yeah. And those are all kind of thoughts in my head. I mean, the other thought was, the concern for trapping of the ventricles with the growth of the tumor, because there may not be connection with the posterior horn and the anterior horn on the left. He also was kind of starting to develop hydro as well. And so likely he's going to need a shunt. And then where do you put the shunt? Do you put the shunt on the left in the temporal, in the left side over the tumor, or on the right side? So we started with a laser. I planned it out carefully so that the solid section in the thalamus was kind of like you said, on the left side was a larger part of the tumor, and the most solid part near the motor cortex and the thalamus I was most worried about. So I thought I'd laser that and then, see how it went. And then if I needed to go in there to kind of remove the other part in the ventricle, I could. So this is what the trajectory here that we used. And then, he ended up getting hydro, which we shunted. But this was his course. We never went in there to bulk at all.
Oh, really?
So post-op day 1. And then, this is now 30 months. He actually just got his 36-month scan. And unfortunately, he has a drop metastasis to his spine. But the tumor control was continued here at that for 36 months, which was an impressive response. He was a IDH wild type, but MGMT positive. And didn't really have any other significant mutations of known. But I think it's just so great to see that you're doing the work in this, because it's, not everybody's going to respond like this. Obviously, why this person responded like this is unclear, and it's obviously something to do with his response not only to LITT, but obviously because he was MGMT positive and to the chemo radiation. But if we could figure out who's going to have a response like this and who wouldn't, that would be super helpful in the first place. And then how do you adjuvant that with immunotherapy? It's funny because all of our papers that we've come out of Miami always say that we really don't even attempt the LITT unless we try to get 85% resection, 85% ablation with LITT only. And this was definitely not that kind of an extent of ablation, but yet he had a really good response. We took a very small stab at looking at kind of just the responses with the data we had 2 years ago. When we kind of just looked at the neutrophil lymphocyte ratio in these patients that underwent LITT, and we found a really weird correlation in that people who had a kind of this neutrophilia response after LITT actually ended up surviving much longer with gliomas. But this was with a very Sorry.
Oh, sorry. I think I probably froze there, right?
Yeah, no, I think I froze too. So yeah, the question is really just, not only how do we adjuvant this, but also maybe even selecting, who will really have a huge advantage to responding to LIT in the future, based on their immune status before and after LIT. You could kind of even understand, okay, did their immune system get revved up by LIT? And then even before you start, your immunotherapy within a couple of days, can you kind of predict who is going to have a more robust response, and who do you go in the immunotherapy group versus who do you go in the chemotherapy group? Do you think you'll be able to, is that something you guys are looking at?
I mean, it's certainly something we're looking at, and we're doing, so we longitudinally bank and immune profile all of our glioma patients. So everybody who undergoes resection, LIT, whatever it is that we treat, we are following them with serial blood draws from diagnosis to death. And we have a lot of kind of studies going about trying to look for different immunologic biomarkers, either the immune cell profile or cytokine profile, that's predictive of who's going to do well and who's not under all circumstances, right? So standard of care, immunotherapy, and those treated with things like LIT or other minimally invasive treatments. Just the amount of data, though, that you need to really parse this out, because there is so much heterogeneity from tumor to tumor and patient to patient. It's just, it's going to take time is the answer. I think we're going to get there, and we're going to have nice predictive biomarkers for who we should treat how, but it's not coming tomorrow, that's for sure.
Yeah. Okay, and lastly, we'll just get to the few questions here from the audience. I think they're pretty straightforward. When you look at LIT and the brain around it, what are the chances of causing damage to the parenchyma, and how do you prevent that from happening?
Yeah, I think that's a very important question, right? So, I've given the sense that LIT is this nice minimally invasive approach, and it's so safe and so forth, but, absolutely injuries can happen. And, for those people who haven't done it, when you do it, it actually is a humbling experience. When you hear people talk about it at meetings and so forth, it seems like you can always cover the tumor the way you want to cover it and get the, it to spread the way you want. But in reality, we often face one of two problems. One, the heat just won't spread in a certain direction, and we undercover an area that we really want to cover. Or sometimes it, goes beyond where we're expecting, or maybe we push it beyond on one direction to try to get it to cover in the other direction. But, heat causes damage, and there really is, irreversible thermal injury that can happen. So the data speaks for itself. The complication rate of permanent neurologic complications is low. It's on the order of probably 2 to 3%, maybe up to 5%, depending on which study you look at. But it does happen. It's happened to me in one case of a thalamic lesion that we treated, that the patient ended up having a little bit of an injury to the internal capsule and ended up with a hemiparesis, permanent hemiparesis, almost hemiplegia. So the best ways are to really know your anatomy, really set your protection areas, and be ready to give up if your heat moves into those areas, even if you haven't ablated what you want, right? So sometimes we really want to get that 90% coverage of the tumor mass, but we see it growing out past the margin in one direction, and we know we're getting close to danger areas. Sometimes you just got to call it quits, even if you haven't accomplished what you wanted. And I think the cases that you guys show are really informative in that case, because sometimes you don't even need a full coverage, and you still get a biologic response, and you still get a nice outcome. And so, don't hurt the patient in order to accomplish what you think you need to accomplish, because sometimes you don't need to do that, and the outcome is still excellent.
Right. Totally agree. Last one is from Dr. Rivas, and he was just commenting on, the matched cohorts and the data on LIT for GBM for newly diagnosed, and whether or not you had mentioned that a lot of those people are kind of in a separate category because they have deep-seated lesions near eloquent areas, and have higher morbidities. And he wanted to know if that was taken into account in those studies. Were those patients dying from their comorbidities, or were they dying from GBM progression?
You mean like in the Lantern study, the recently published? So the answer is I don't know. I wasn't actually a part of that publication, and I didn't review the raw data. I've only seen the grouped published data, but it's my assumption and a little bit their assertion that that is the case because of the patient selection, right? And that's a database that spans many years since the earlier days of using LITT for treating gliomas, where I think it was primarily reserved for those tough cases where you wouldn't really attempt an open resection. I think things are shifting and there's more acceptance now of patients where there's equipoise to try LITT as a minimally invasive alternative. And so what will be interesting is the data that comes in the next 5 years from the patients that we treat now who should have, at minimum equivalent outcomes to equivalent outcomes to open resection, if not better.
Yeah, totally agree. Totally agree. Okay, well, I think we're a little over time. I want to thank you again for your time. I know you have a busy schedule, but that was really great work, and looking forward to seeing the next step that comes out of the lab.
Great. All right, thank you for having me, guys. It's been awesome. Keep litting.
Okay, thanks. Take care. Bye.